Thank you very much, Mr. Chairperson, ladies and gentlemen, and good morning. My disclosure information. Let me start from the definition of intramural VT. The definition of intramural VT is that the VT focus is localized at the inaccessible mid-myocardial substrate. It has been known that 11% of septal substrate of ischemic VT and 20% of LV outflow to VT may have an intramural substrate. What are the diagnostic criteria for intramural VT? First, far-field electrum is earlier than near-field EGM at the earliest activation site. Pace map is suboptimal. Overdrive pacing shows manifested entrainment. We know the optimal bipolar voltage cutoff determining myocardial scar is 0.5 millivolt and the health myocardium is 1.5 millivolt. A UPenn group suggested unipolar voltage reflects a subepicardial substrate and its cutoff value differs depending on the mapping sites. However, these cutoff values were determined by standard mapping catheter, not the multi-electrode high-density mapping catheter. Therefore, the standard voltage level could differ depending on the catheter configuration, electrode size, and wave direction. French group also suggests the LABA, local abnormal ventricular activity, with specific criteria. During VT mapping, both bipolar and unipolar electrograms are used for activation mapping. Although QS pattern of unipolar EGM suggests the exit site, Wendy Zhou recently reported that the activation timing of unipolar QS is also very important. If activation timing of unipolar QS negative DVDT is later than bipolar EGM activation, real VT focus could be somewhere inside. So we have to carefully observe the activation timing, unipolar QS morphology, and also activation time difference between bipolar electrogram and unipolar electrograms. After the introduction of high-density mapping catheter technology, substrate mapping became easier and more accurate. Roderick Tong suggested isochronal late activation map, so-called ILM, and he defined the acceleration zone as 3 isochronal colors per 1 centimeter distance. And you can localize deceleration zone at the Scott-Bordeaux zone during sinus rhythm. Then you can induce ventricular tachycardia and map the functional substrate. If you watch the ILM, including red to purple color without skipping activation color, that might be the perfect ablation target. However, we have to keep in mind the ventricular wall is 3D structure with significant thickness. If you map the complete isochron crowding from red to purple at the endocardial surface or epicardial surface, you can ablate them at the reentry core isthmus. However, 18% of non-ischemic VT shows intramural reentry, including mid-myocardium. In this intramural reentry, you cannot map perfect isochron crowding in both endo and epi. Probably there is an inside of intramural reentry. Della Bella used both ILM and the late potential map, and by utilizing high-density mapping catheter at the isochron crowding area, he could map the entrance, isthmus, and the exit electrogram, mapping the late diastolic potential. He achieved a very good success rate with those area showing the perfect complete diastolic pathway map. However, you cannot get such a beautiful 2D functional reentry in these cases of intramural reentry, which occupies 18% of non-ischemic VT. Stevenson reported sophisticated mapping of peri-aortic VT in patients with non-ischemic cardiomyopathy. They applied the different bipolar and unipolar voltage cutoff levels depending on the distances from the aortic ring, and peri-aortic VT substrate were mappable in 38% of non-ischemic VT. Moreover, the proportion of VT showing LVV morphology and RVV morphology were half and half. In case of LVV pattern, it was easy to terminate, but shows a high chance of heart block. In contrast, in case with RVV pattern, the VT target existed more laterally and showing only 70% chance of termination due to deep intramural substrate. Then what's the role of cardiac MR in intramural VT map? Markolinsky group reported cardiac MRI provides 83% septal substrate and 37% mid-myocardial scar in patients with non-ischemic VT. They suggest the importance of transseptal conduction delay in addition to low bipolar and unipolar voltage. In this MRI study by Nishimura, the septal late gadolinium enhancement pattern affects the outcome of anteroseptal VT ablation. Compared to the case with partial septal scar, the patient with full-length septal scar or T-shaped scar involving both ventricles shows a significantly worse outcome after VT ablations. However, we have to keep in mind the limitation of MRI late gadolinium enhancement to define the VT substrate. This sophisticated study compared the human heart histology and cardiac MRI and electroanatomical map in patients who underwent non-ischemic VT ablation. The authors concluded that the searching for any distinctive voltage cutoff to define the fibrosis in non-ischemic VT is futile. In this example, you can appreciate 27% of fibrosis in this area without any late gadolinium enhancement. It's clean area. Therefore, we have to recognize the limitation of the spatial resolution of cardiac MR, especially in patients with non-ischemic VT. So far, the correlation between MRI late gadolinium enhancement and histology was only proven in an animal model of ischemic cardiomyopathy. Now, we understand the ventricle has a 3D structure and significant thickness. Although epicardial mapping might be very helpful in understanding the mechanism of VT, it is not practical to do epicardial puncture in every single patient without any evidence. However, the cardiac veins provide an excellent site for mapping, pacing, and potentially ablation. Garcia suggested a careful coronary venous mapping, including AIV, septal vein, and perforating veins using 2 French microcatheter, and it is very useful to look for the subepicardia or intramural VT foci. You cannot ablate inside the small coronary vein branches due to the high impedance. However, you can target the earliest activation site by visual estimation of endocardial approach. It is quite effective to ablate subepicardial or intramural VT ablation. If you look at the coronary venous anatomy carefully, you can map not only septal veins, but also communicating veins, which locate between coronary artery trunk and aorta. This septal branch map is used for targeting intramural septal VT, and this communicating vein provides a good target for LV summit or LV outflow VT. In this example, you can map the communicating vein by PCI guide wire and ablation from corresponding endocardial side. This is decision tree provided by Garcia. You can try endocardial ablation at the earliest activation site if it is the endocardial focus. If it is intramural focus, coronary vein mapping is useful, and you can start with endocardial ablation as opposed to the earliest activation site inside the coronary vein. If it is subepicardial focus, you need to map the corresponding endocardial site first. If wall thickness differs within 14 millimeter between epi and endo, and the activation time differs within 7 milliseconds, you can try endocardial ablation first. Otherwise, you have to consider epicardial or coronary vein ablations. Next, let's discuss effective ablation strategies for the intramural septal VT. I'm using half normal saline wherever to ablate VT with significant substrate. Half normal saline has a low charge density, increase the impedance surrounding the ablation catheter, and reduce the RF energy dissipation. It is useful in the region with low blood flow, but you have to be careful of the stim pump at the high contact force. Simultaneous unipolar RF ablation is also effective for intramural VT ablation. You need to use 2 ablation catheters and 2 generators, and simultaneous unipolar ablation minimize the convective cooling and increase the conductive heating. For the better lesion formation, the perpendicular ablation catheter orientations of 2 catheters is more effective. And unlike to the bipolar ablation, lesion directionality, impedance mismatch, and stim pop are minimized by this technique. In contrast, bipolar RF ablation utilizes just 1 generator. You can connect the active catheter to the generator and return catheter to dispersive patch. And because of risk of return catheter overheating, sometimes 8 mm large tip return catheter is recommended. However, large tip return catheter is inside the coronary vein has a risk of vascular damage. Therefore, the best way might be using the 2 irrigation tip catheters. 2 ablation catheters should be closed within 15 millimeter, and there is no consensus for optimal power and duration. And you have to be very careful if the target site is close to the coronary artery. Another option for intramural VT ablation might be needle ablation. 27 gauge needle with warm saline irrigation RF generates huge intramural lesion like this. However, a recent proof of concept pilot study shows relative high complication rate. The last one is alcohol ablation. Both transcoronary arterial injection or coronary venous injection could do it. And although it could apply for the bailout redo procedures, an early pilot study shows 25% of recurrence, and these longer-term follow-up data. Last but not the least issue might be high-risk patients. Most of the patients with intramural VT are fragile patients with heart failure. So we try to our best to eliminate ventricular tachycardia, but we should not eliminate working myocardium or patient. UPenn group suggested PANST score, including COPD, AG, ischemic cardiomyopathy, heart failure, storm, and diabetes. And actual 30-day early mortality after VT ablation with heart failure is known to be about 5%, but early mortality is even higher in patients with high PANST score over 15. Because blood pressure and circulation becomes very poor after VT induction, you need to carefully monitor the cardiac output, arterial pulse contour, SVO2, or lactate level. Percutaneous LVAD, so-called impeller, is very useful in patients with hemodynamical instability, and the labella provide this decision tree. And the problem is the early weaning of impeller LVAD could result in decompensatory heart failure. Therefore, cardiac output, PH, lactate monitoring is essential for those high-risk patients. Recently, MRI scar or CT wall thickness guided substrate ablation was suggested for high-risk patients. No electroanatomical map, no VT induction, but just substrate and imaging-based ablation. This is a CT wall thickness map and electroanatomical map acquired from the patient with non-ischemic VT, which we ablated 3 weeks ago, except for the artifact on the diaphragmatic attach area. Thickness and voltage map shows some similarity. The last one is radioablation. After first report from Washington University in 2017, many centers tested this non-invasive ablation technology. In this recent report, SBLT shortens the QRS width and increases conduction velocity at the scar border zone by reprogramming of gap junction and sodium channels. However, we need the longer-term clinical outcome of VT radioablation. Okay, this is my take-home message, ladies and gentlemen. What you see at the 2D map is not everything, and careful watching for far-field signal is the key to targeting the intramural VT. Coronary vein, unipolar, ILM, epicardial maps may visualize intramural VT targets. Late gadolinium enhancement may be useful, but cannot show all the histological changes. Half normal cell line, simultaneous unipolar or bipolar needle catheter or alcohol ablation may improve the success of intramural VT ablation. Paced score or percutaneous LVAD backup could be helpful for safe ablation, and less invasive ablation strategies need verification of their effectiveness. Thank you very much.